So some guiding principles around evaluations and diagnostic work, okay? The first thing is that diagnostic evaluation should avoid confirmatory bias, okay? So why would that be an issue with ADHD or a diagnostic evaluation? Why would we have to be concerned about confirmatory bias?
Because many people have some of the symptoms, and if you're just looking for it, oh, there I see it, you must have it.
Okay, so many people have some of the symptoms, if you will, and everybody behaves in a way that is inattentive at times, okay? And so we have to be careful about that. And so there are a couple of issues here in particular. One is that someone might say, I think this child has ADHD, okay? Then we might get a tool out of our toolkit that has the word ADHD in it. So it's an ADHD rating scale. And then the child scores high on that. And we say this, of course, now proves that the child has ADHD. That would be a classic example of engaging in assessment that is fraught with confirmatory bias. Alternatively, we should be looking at ruling out other explanations for inattentive behavior. So we should be considering anxiety problems, depression, lack of sleep, and other kinds of issues. And if we rule all of those things out and we say we can't rule out ADHD because of all these other data that we have, then we would have avoided confirmatory bias. The people, I'm not beating up on these people, but the people who engage in assessment that is fraught with confirmatory bias the most are pediatricians. Okay? Mainly, I love pediatricians, I love to work with pediatricians, but mainly because they are office bound, they will use diagnostic rating scales as a primary or sole tool to identify children with ADHD. The problem with that, it's not that they're not well intended, but it's that they're not avoiding confirmatory bias. So a parent says, a teacher said this, I'm coming to you to ask about it. You asked me to fill out a rating scale. The scores are high. You say, yep, the scores are high. I think it might be ADHD. Now what do we do next? Now we try some medication, and let's see how the child responds. Okay, so now we've got a bunch of problems wrapped up in there. But that's not atypical in our communities. Okay, so we want to be aware of this, and we want to try to avoid it if we can. All right, you with me? All right. So we want to try to avoid confirmatory bias. We want to use a multi-method, multi-assessment, or multi-method, multi-informant, multiple setting assessment whenever possible. Schools are the best place to do that. Okay, schools are perfect places to help contribute to a diagnostic evaluation or to conduct a diagnostic evaluation of ADHD, because you have ready access to multiple settings, multiple informants, and multiple methods: direct observation, rating scales, other kinds of assessments, interviews, and so on. Okay? If you don't know the word diagnostic homogeneity, this is a vocabulary lesson. So diagnostic homogeneity is another critical issue here. We want to recognize that diagnostic homogeneity does not exist with ADHD or pretty much any other psychological or psychiatric condition. Diagnostic homogeneity means that if all people having the same diagnosis present with the same symptoms and have the same etiology and the same course of the problem that they're experiencing. With ADHD, we have diagnostic heterogeneity, a wide variability across all people with the same diagnosis. What that means is the diagnosis is simply a starting point for designing a support plan. It's not an ending point. To guide our treatment and support, we really need to understand three primary issues: severity, chronicity, and the function of the problem behaviors that we're seeing, or the functions of them. Okay, so severity, how severe relative to typically developing children of the same age and gender. how chronic, how long has this been going on, how long is it likely to continue. We already know that ADHD tends to be a chronic problem. And then the functions of the behavior are going to vary across children, so we're going to have to do some individualized assessment and understanding there. Okay? Relative to ADHD, we want to think about the disruptive behavior disorders of childhood, ADHD, ODD, or oppositional defiant disorder, and conduct disorder. And we want to think about the criteria for ADHD, which you've seen in many places, and which aren't going, we're going to have DSM-5 in any day now, and things aren't going to change very much, but a little bit, but probably not very much at all. But what we have are significant problems with inattention, hyperactivity, and impulsivity, symptoms present for at least 6 months. Okay, symptoms caused impairment before age 7. Okay, so those two issues, and some impairment or 2 or more settings, those 3 issues are the stumbling blocks to a good evaluation. Okay, so we need to establish the chronicity of the problem. So we have to do some history and through diagnostic interviewing and records reviews. We have to establish that the symptoms caused impairment before age 7. Okay, now that's tricky, and that's one of the issues that comes up when we first are identifying kids at the secondary level. Why didn't this come up before? And that's where we get into this confusion and a really difficult time of trying to parse out what's due to academic difficulties that have gone on for a long time and what's due to ADHD. And the primary issue is going to be looking at academic history and achievement history relative to developmental history, and when did behavior problems and impulsivity and attentional problems first emerge, and did they emerge in concert with academic problems or separately. That's going to help, that kind of thinking is going to help us to parse out as best we can this issue. And I'm not saying that I can do that perfectly or that you can do it perfectly. We're always going to have to rely on our best professional judgment relative to all of the information that we're able to gather. Okay? So that's a particularly challenging issue. So impairment in social or academic or occupational functioning, not due to another disorder, and then we have this combined type and primarily inattentive and primarily impulsive type. Okay, so these are the inattention symptoms. I won't read all those to you. You've seen those before. These are the hyperactivity and impulsivity symptoms. Fidgets, leave seat. On the go, talking excessively, difficulty awaiting turn, interrupting others. So impulsivity also, I mean, people use, for impulsivity and inattention, they use these computerized assessments as well. Some of you may use something like a continuous performance task. There are some of these are available to put on your personal computer. So a child might be shown a set of letters that show up on a screen, A, B, D, that show up randomly. And then you ask the child to push the button, push the enter button or whatever button, when you see an A followed by an X. And don't push the button any other time. Okay? So children with ADHD in laboratory-based studies make more errors of omission. So the A is followed by the X and they don't push the button. And they make more errors of commission. They push the button when they shouldn't have than typically developing peers. So that's attending to a very focused task. And we do see some of that type of behavior in general in the classroom as well. But you could supplement some of your assessment with a computerized task like that. There's also there's an impulsivity task. It's very old. Like me, I used it with my dissertation. It's called the matching familiar figures task. Okay, so a child is shown a stimulus picture. It's a boat. It's a line drawing. And then on the bottom there are 6 line drawings of 6 boats that look very much like the top one. And the child is asked to point to the one of the 6 that is exactly like the stimulus picture. Okay. Children with ADHD tend to respond very quickly. It's that one. Okay. And they tend to make a lot of errors. So on that task, you point to pictures until you get the right one. Okay. So kids with ADHD will respond almost immediately. It's that one. And you say, nope, sorry, try again. And it's that one. Nope, sorry, oh, it's that one. And then eventually, within a very short time, they get the right one because they've gone through many of them. Okay. But kids without ADHD, and people have actually done eye movement studies with the matching familiar figures test. So a typically developing child looks at the stimulus, they look at the 6 pictures, they look at the stimulus again, they narrow it down, they look at only a few, they look back at the stimulus, and then they make a choice, and they're very likely to get it correct. Okay? So that would be lots of corrects, very few errors, and you also time the response to the first choice. Okay? So kids with ADHD respond very quickly the first time, and they make a lot of errors. But if you think about how that generalizes to tasks in general, you can see how kids with ADHD and adolescents with ADHD can get themselves into trouble when they have to follow rules, when they have to follow directions, when they're 16 years old and they have to start driving a car, how careful we need to be. Okay. The reason I'm taking time to just mention those is that you want to be thinking about, is this the kind of presentation that I'm seeing? That children are making lots of errors of omission, errors of commission with respect to making academic choices and engaging in academic behavior. And then also, where they have choices, do they tend to make those choices quickly and with high rates of errors, if you will? Okay, so those are some things we need to be thinking about. Blurting out answers before questions have been completed. So it occurs in about 3 to 5% of children. And why is that important? Well, it's important because at our school district levels and in general, we talk about this issue of, I think ADHD is over-identified. Okay. If we're going to pursue that line of reasoning and discuss that in our districts and with administrators, we need to have a standard. So, all right, let's raise it up a little. Let's go with 5 to 7%, okay? Because we've been diagnosing more kids with this disorder. If in your school district you've got 15% of your population, or in a particular elementary school you have 22% identified with ADHD, I've worked in a school, elementary school, where we had like 30% in a couple of grades. And one of the things we found is that many of those children had the same pediatrician in common, and it was a common issue in that community for parents to be talking with each other about this and to sharing this pediatrician. Lo and behold, a lot of kids ended up with a diagnosis of ADHD. And so we had a lot of work to do to try to sort some of that out and think about systematic evaluation of concerns that people had. Why was this being done? How could we communicate and collaborate more with a pediatrician in the community, and so on. So it's possible that you will have schools or school districts that have relative higher rates than expected. And that's the term I think we should use. This is a higher rate than expected. This is not really different than saying we have higher than expected rates of reading problems in 4th grade, and we need to think about what's happening in K1, 2, and 3 with our core reading curriculum. So we can use the same kind of logic for thinking about how many people are being identified with what types of problems, and is that reasonable or is it beyond expectations? We're seeing in school and community-based mental health centers, as well as with child psychiatry and psychology, lots and lots of referrals, and we find ADHD across ethnic groups, across countries, although the highest prevalence is in the U.S. Probably because we have the highest number of service providers available, and we have the best communication, if you will, about health problems, health systems, and so there's a high level of awareness of a variety of different types of problems in our society, and so we have a higher prevalence of identification of lots of different things for those kinds of reasons. That's a good thing at some level, and it's a problematic thing at another level, but it is what it is. I just wanted to show you that the things I'm talking about with you, this is from Pediatrics, the official journal of the American Academy of Pediatrics. These are the clinical practice guidelines for pediatricians. And they're similar to what we're talking about today. Okay, so pediatricians are moving in the same direction. Their awareness is being raised. They're getting more to the point where they're focusing also on multi-method assessments. So, so this is talking about children ages 4 through 18, that a pediatrician should initiate an evaluation for ADHD. To make a diagnosis, you're looking at the DSM criteria and seeing if they're met, including impairment in more than one setting. Okay? Information should be obtained from parents or guardians, teachers, and other school professionals. The third issue is that consider that should include assessment of other types of conditions. Okay? So I'm showing you this again as a talking point and as something that can be shared with people in the community and with parents around issues. So one of the positions that people in school are frequently put in is parents walk in with an assessment or a diagnosis and they want us or they want you to respond to that. Sometimes you'll have concerns about that assessment, that it wouldn't meet these guidelines, for example, or it wouldn't meet the idea of a multi-method, multi-informant, multi-setting assessment. It's legitimate for you to raise those questions, not necessarily in an antagonistic way, but in a way to how can we get the best services for a child? How can we be sure that this is something that we're dealing with the right identified issue here? And do we need to do more in the way of assessment before we actually respond to this by developing an intervention or by making a child eligible for special education services under the other health impaired category or other types of actions that we might make. So I'm showing you this just to talk briefly about the issue of over time we're in more of a relatively common place with pediatricians, other physicians, family health providers, family physicians, and child psychiatrists around guidelines for ADHD. There's relative agreement about the kinds of assessment that is appropriate. So you have lots of places to turn for talking points, if you will, to have those conversations. So let me stay here for a second. So one of the things I want to encourage you to do is to, in your school systems, to proactively make contact with physicians in your community. And you can do that. I've worked with school districts. One way to do that is a couple of times a year to organize a meeting of local pediatricians at the school, or at least invite people. And if you do this enough times, you're going to get people starting to come in. You can go out and you can talk about diagnosis of ADHD. That's going to be a big issue. Diagnosis of other types of disorders. How can we communicate well together? What information could we provide you around the children that you see on a regular basis that could be helpful to your practice? How can we best communicate? So if we have a child under your care and we have questions about, who can we talk to in your office? What's the best way to communicate? Is it by phone? Is it by email? Is it by letter? Those kinds of things. So starting to establish lines of communication with physicians in your community is a really important idea. In many communities, well, especially in many schools, we could probably identify a manageable set or a small number of primary service providers. Some places we're going to have more trouble with that. But it's worth the effort to open the lines of communication between school-based personnel and community-based physicians around these kinds of issues. We can avoid a lot of problems, and we can establish some more collaboration than we would without that communication.